Now, if you are in a row where there are less than 4 rows in front of you right now, you need to pick up your handbag and move up at least 5 rows. All right, so what I'm saying is if you're in the back 4 rows, you need to move up. All right, so everybody move up.
All those people in that back corner, they need to move up.
Those people in the back corner, okay, the back corner, those are our volunteers, and they can stay there, but you guys in the back 4 rows, I want you to come up to the front. Everybody move on up. Come on in, move on up. So the back 4 rows are now closed. No one is allowed to sit in the back 4 rows. If you sit in the back 4 rows, there will be severe penalties and consequences. I'm not sure what they will be, but they will be severe, and you will be very, very sorry that you sat in the back 4 rows. Okay, so no one sit in the back 4 rows. Don't go anywhere near that back row. No, 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 don't do it. No, wrong row. Oh, getting your stuff. Okay, that's allowed. All right, we'll let you do that. Okay, where has everybody's getting their flu shot, Lizette? Is that where they are? They're getting their flu shot? Or they're signing up for the blood bank, maybe? They're all signing up as blood donors? Okay, how many people did their homework on that coffee break? How many thanked a volunteer? Awesome. How many people got a flu shot? Anyone? Excellent. Anybody sign up for the patient portal? Oh, good, a few people. That's great. How many people thanked one of our exhibitors? Like when you grabbed the stuff, did you say thank you?
I did.
Okay. I saw a lot of action out there. There was a lot of stuff changing hands, and I'm hoping that it was all accompanied with thank you for your support of the healthcare conference. Yeah? Okay. All right, so good morning again, everyone. We have reached that bittersweet moment for me that we hit every year at this time, which is our final presentation for the healthcare conference. It's hard to believe that we've actually come so far in such a relatively short period of time in the last 2 days, 3 days. Have you all enjoyed the presenters that we've seen so far this morning? And we've had some fantastic, fantastic speakers over the last couple of days. So those of you who just came in late, you missed the announcement I made earlier, which is that the back 4 rows are closed, and you must not sit in them or I will be very, very cross. So if you come in late and you've sat in the back 4 rows, I need you to pick up your stuff and come up into, you could go to the 5th back row, but not the 4th. So everybody, we're trying to get you up a little closer. We don't want you to miss any of the action. Okay, come up and fill it in. Okay, awesome. So big thank you to the coffee break sponsor, DART. Can I get a round of applause for them? And I want to welcome and acknowledge the Honourable Minister, the Honourable Dwayne Seymour, who's our Minister for Health, Environment, Culture and Housing. Good morning, sir. And also our Ministerial Councillor, Captain Eugenie Banks, is here this morning as well. Welcome, sir. And I understand that Minister O'Connor-Connolly is here as well. She is the Minister of Education, Youth, Sports, Agriculture and Lands. Maybe she's getting a flu shot or signing up for the portal, but I'm sure she'll be in a moment. So welcome and thank you all for coming. So here we are. We're back for our final speaker. Well, almost final. The minister gets the last word. But our final presenter for this morning, which is Dr. David Greenburg, who is a physician and a healthcare expert. So a couple of things. Don't run away after Dr. Greenburg is done, because I have the winner of the Fitbit Versa, which I will announce afterwards. You got to stick around. Don't forget, you want to recycle your lanyards. We're also the ministry responsible for environmental health and the landfill, so we want to recycle. There are some, at the table on the way down the hall, you'll see some bins there, so you can just drop your lanyards in there on your way out as well. Okay, so Dr. Greenburg is here, and he's going to talk to us today about the empowered patient and the internet, a family physician's challenge. Dr. David Greenburg is currently on staff at St. Joseph Health Centre, where he plays a leadership role in the areas of family medicine, obstetrics, and continuing medical education. Dr. Greenburg was formerly the Chief of Family and Community Medicine and the Chief of Emergency Medicine at Doctors Hospital, a community hospital where he took a leadership role in the industry-wide transition to a focus on ambulatory care. He is also the chairman of Continuing Medical Education. Dr. Greenburg is recognized as a skilled communicator, able to effectively convey highly complex issues and concepts in a straightforward and entertaining manner. He's become a highly sought-after speaker, delivering addresses on a broad range of topics across North America and Europe, and we're very lucky that we were able to get him to come here. He has hosted several educational videos for both physicians and patients and has appeared on many television and radio programs dealing with healthcare issues. Dr. Greenburg has written a variety of educational articles which have been published in popular medical journals. He has been the co-editor of the 2007 and 2008 Canadian Clinical Practice Guidelines, a compilation of 32 different clinical guidelines that is distributed to 22,000 doctors across Canada. He has also recently completed editing the Canadian Men's Health Guidelines, which are currently being distributed to over 25,000 GPs and nurse practitioners across Canada. He's going to speak to us today about the empowered patient and the internet, a family physician's challenge. Ladies and gentlemen, please welcome Dr. David Greenburg.
Thank you. I think my mother wrote that. That was way, way, way overkill. And if Jen would have introduced me as her former aerobics student, that would have been fine as well. I don't really need all that stuff. But before I start, I just want a few thank yous. First of all, I want to thank Jennifer and the ministry for hosting what is unequivocally my favorite conference of the year. And say nice things about me so they'll invite me back. She mentioned that I'm a highly sought-after speaker. I want to thank Lizette and whoever was on the vetting committee for actually deigning to allow me to speak here. I get more scrutiny about what I'm going to say than any other conference in the world here, but thank you. And I want to thank Grace and the team from Tower for making it really easy for me to get here. So and the sponsors, and thanks to all of you. I want to congratulate Dr. Scott. This is a tough act to follow, but I'm going to do my best. I made sure I came to hear his talk for a couple of reasons. First of all, because I thought it would be interesting, but also there's going to be a tiny little bit of overlap, but there's a slightly philosophical difference in how we're presenting things. So, and I was quite relieved for the fact that I got all the answers right, but I didn't want to say anything because I figured it's cheating. Okay, so next slide is the single most important slide. Read it very carefully. Where's my click? There we go. Yeah, so this ain't science, kids. This is fun. So, and I'd like this to be as interactive as possible. Oh, so this is our objective. So by the end of the talk, we're going to learn how to have a meaningful conversation with your healthcare provider without totally pissing them off. So, hopefully we'll get through this nicely. And what my hope will be, and as Dr. Scott was able to do, it'll be very interactive. So I have no problem with people asking me questions as we go. And I was thinking that in order to make it as interactive as possible, maybe we could all just introduce ourselves. So let's start off in the corner. No, we don't have time for that. Okay. So, but the other caveat here is a lot of this is based on my personal experience, which is as a GP in downtown Toronto. Toronto, I just read in the paper this morning, is now the 4th largest metropolitan center by size in North America. So it's a big, big city. We have different kinds of access issues than other places. One issue we don't have is funding. Everybody goes to the doctor, whether it's GP, A&E, whatever it is, for free. And that's not one of the problems, but there are 1 million. So I live in a province called Ontario, for those of you that aren't familiar with Canada. There's about 9 million people that live in Ontario, and there's 1 million people in Ontario right now that don't have a GP. So these are the kinds of people that are accessing walk-in clinics, and unfortunately for Dr. Scott and his colleagues are accessing emergency departments for what should be routine care. I recognize the fact that the Caymans are different, and I'll try and be sensitive to that, but a lot of this is somewhat Toronto-centric, unfortunately. But feel free to give me a hard time, because my wife's not here and somebody has to. Thank you very much. I'll be here all week. So it's very, I got to stay between the flags. So it's very important to remember that all successful adult relationships are based on two necessary but not sufficient conditions, okay? And the first one is mutual trust, and the second one is mutual respect, okay? And your relationship with your physician or health, I'm gonna say physician, recognizing the fact that there's some people that access nurse practitioners and other sort of allied health people, but let's just say doctors for that'll be my shorthand. And if I happen to say guys, I mean people. Every once, I'm not being, I'm not being anti-woman. Sometimes I fall into that. I apologize. So what happens if you don't trust your healthcare professional? Find another one, if that's possible. Okay, and that may be a challenge. Okay, but the other is if you don't treat them with respect in terms of their expertise and their time, you're probably going to create a problem where one didn't exist or need to exist. Okay? So it's a two-way street. Your time needs to be respected, your knowledge needs to be respected, but it does go both ways. And one of the challenges of the internet is that second piece is becoming more of a challenge. Patients used to look stuff up on the internet and make suggestions. Now they look stuff up on the internet and tell me I'm wrong. And that's okay, because it just takes me a little longer to explain to them why I'm not, but it does tend to, and some people don't tolerate it as well as I do. So what's the biggest problem with the internet? So this fellow is Tom Nichols. I heard him on TV last week. He's quite brilliant, and he's at Harvard, and he's a national security expert. And he wrote a book that's called The Death of Expertise. And as many of you know, I'm not sure about, well, you get all American television and radio here. The problem is that now, when you listen to talk shows and people calling in and you watch CNN and they've got 7 people listed, when everybody's an expert, nobody's an expert. And everybody now feels that their opinion is worth the same as everybody else's. And in the States, in fact, as some of you have seen, and I don't want to offend anybody politically, but there is this, like what he was talking about with this flat earth movement. And there's a whole bunch of people in the United States who believe that the earth is flat, and because it's not part of their experience, don't confuse them with the facts. This is my opinion. I've never seen the end of the earth, so therefore it can't exist. So this is a problem. So we have the death of expertise and people not taking experts as seriously as they did or should necessarily. But this was a great quote from him, which is that oftentimes younger people will say that the internet is just a big library. When in fact, that's wrong, because what the internet is a dumpster, okay? Which is not to say that you can't find valuable things in a dumpster, but you gotta wade through a lot of stuff, and you gotta know what you're looking for, okay? So as he says, there's no guarantee that anything you find on it is actually true. And, so one of the things that, with this focus on fake news and fake news and fake news, we're going to come back to those. Of course, there are other problems with the internet. I'm sure that some of you are familiar with this concept as far as the internet goes. This is from a play called Avenue Q. I don't know if you've ever seen it before, but that's, among other things, that's what the internet's good for. So what was the most important thing we were taught in medical school? There were a bunch of most important things. One was we were told on our first day that if by the end of 4 years you can tell who's sick and who's not sick, we'll have taught you everything you need to know. But ultimately, the one thing, this is Curly from City Slickers, the one thing that they told us was the most important thing was how to evaluate research. That was our job, to figure out what was true and what wasn't true and how to guide our practice based on that. So, this is me evaluating research. But now we have a whole new problem. And what's the new problem? A couple of problems. One is this proliferation of journals. So what happened is, Dr. Scott's much younger than I am, I think, but when we were growing up, one of the things that, what did we have access to? We had The Lancet, we had JAMA, we had the New England Journal of Medicine. In Canada, we had the Canadian Medical Association Journal, but that was pretty much it. And you could probably trust what you read there. So one of the things that's happened is that with this proliferation of academic medicine has become this whole publish or perish thing, Well, if people are going to publish stuff, they got to publish it somewhere, and the people who are in the publishing business recognize that there's this niche, and now there's virtually no subject that you can't find a journal that's dedicated to. Who knows if the stuff is any good or not? So that's one problem, is that just because it's published doesn't mean that it's meaningful in the way that it used to be. But here's, on a click, sorry. So here's one problem that I never saw coming, vis-a-vis all these other, prior to all this proliferation of journals, that who are you going to trust? Okay, now this fella is the father, and by the way, everything I'm going to show you has come up in the last 3 weeks. So just in case you think that I'm like cherry picking, okay? So this fella's son goes to summer camp with my sons. He was the top researcher at Memorial Sloan Kettering, which is, I mean, that's it, right? I mean, as far as cancer goes, you can't find anything, maybe different, but not better. And he had to resign his position because he sort of overlooked disclosing about $1.5 million he'd received from the pharmaceutical industry. I got no problem with people taking money from pharma, but you know, the rules today are you're supposed to say it. Now, this lady, who was with the Canadian Medical Association, they had to resign from the world body because the incoming president basically plagiarized the Canadian Medical Association person's speech from 2 years previous. This was really interesting. These people slipped restaurants and dog park sex into some of these journals that aren't particularly well vetted. But it's there, it's published, okay? And finally, this was from 2 days ago. This is Harvard. You've heard of it. They take themselves pretty seriously. I always took them pretty seriously. 31 studies, not one, but 31 studies by this doctor were found to be falsified that had to do with injecting stem cells into people's hearts to try and improve their heart function. So, who are you going to trust? It's getting really hard to know. Here's another problem, which is litigation, and this sort of reflects how things get ordered when you go to the internet. And this is a much bigger problem that is in the US than it is in Canada. And as you know, we can have an adult discussion enhancing beverage after it's over, and we can talk about why it's a bigger problem in the US than Canada. But at the end of the day, what it does is the websites have to show you the worst case scenario to avoid being sued, right? So, as it happens, if you look up chest pain, the internet doesn't ask you if you're a triathlete or a smoker, it just says you better go to A&E, right? Because you could be having a heart attack. It has to say that. So, and for those of you, does anybody know who this is? Do people recognize him? House? Okay, so part of the reason you know, one of the doctors that I worked with who was sort of my mentor in, can I have some water please? Who was my mentor in internal medicine, I used to joke that if he was on House, the show would be over in 4 minutes because he wouldn't guess the least likely thing first, he'd guess the most likely thing first, he'd do the one test that would establish it and he'd be right. But you can't sell commercials in 1 minute, so it's in 4 minutes, so it's hard to do. But let me tell you a story about something that happened, and this has to do with the internet approach, which is also an approach that we were exposed to when I went to school. I went to school at a school at the time was called the University of Western Ontario. It's now called Western University. And they told us, excuse me for a second, that at the end of 4 years, they wanted us to be great generalists. We could all go out in the world and be great GPs right off the bat. And part of the way you can do that is by following things like common things are common. Unfortunately, there are other schools, where I happen to be on faculty now, where the students are taught more to impress their professors with how much they know. So this is a fellow who looks like a fellow that when I was in medical school, there were students from Western and there were students from University of Toronto. And you walk into the guy's room and there's an 85-year-old guy lying in bed with an IV who's got a fever and a cough, okay? The Western student says he's got pneumonia. The U of T student says he's got sarcoidosis. It's on the list. It's not very high on the list, mind you, but it is on the list. So having that approach where there's some common sense involved and common things being common is really helpful. But again, on the internet, you're going to get the whole gamut, and how are you going to figure out which to switch? So
Hen's teeth.
Hen's teeth, correct. So this leads us to, and Dr. Scott already did a good job of trying to teach you this, so how do doctors really think? Okay, so to start with, I'm going to tell you a quick story. Does anybody recognize this scene? This is from Alfred Hitchcock's Strangers on a Train. Okay, this picture, I was trying to find the right picture and it took me a couple of shots, so I thought I'd share them with you. This scene is from, who knows? What movie? Casino Royale and Vesper Lynd, and they're sizing each other up at this point. And Vesper Lynd has already decided that he's an orphan, and then when she presents him with a dinner jacket afterwards, he says, I've already got a dinner jacket. She says, well, this one's tailored. How could you present me with a tailored dinner jacket? She sized him up while they were just sitting there. At least that's the way the movie plays out. But here's the real story I want to tell you. And this has to do, and forgive me, this is a little, I hope you'll get it because it has to do with my background. So once upon a time ago, there was a train in Eastern Russia, actually in the Ukraine at that time. And it was going from a big city called Odessa to a small town called Obadivka, which is where my dad's parents came from. And on this train was sitting this rabbi, and in walked a man who was very, very nattily dressed, and he had a big briefcase with him. So the rabbi sits there and he's looking at this guy, and he's trying to figure out why he's going to Obadivka. So he says to himself, well, he's dressed like that and he has this briefcase, he must be a lawyer. But is there anything going on in town that somebody would need a lawyer for? So, well, actually, there was a disagreement between Mr. Levy and Mr. Schwartz that Levy claims that Schwartz, that he paid for a horse, but he sold him a mule. Okay, all right, well, that's good, but that doesn't seem like the kind of thing that you would spend a lot of money on to get a lawyer from Odessa. So how's that? So he says, oh, I remember about 30 years ago, I officiated the wedding of Schwartz's sister. And Schwartz's sister married a guy called Cohen and moved to Odessa. So this must be Schwartz's nephew, because they couldn't afford him otherwise. And then he says to himself, okay, well, but if he's a lawyer from Odessa, right, he wouldn't call himself Cohen, he would call himself Khan. And if he was a lawyer from Odessa, he wouldn't want to be referred to as Mr., he'd want to be referred to as Doctor. So he leans over and he says, Dr. Khan, do you mind if I open the window? And Dr. Khan says, with pleasure, but how did you know I was Dr. Khan? It was obvious. So, how does this apply? We profile. That's what we do, okay? And how do we profile? That was an example. Oh, so we've got a bunch of things: age, sex, occupation, lifestyle, socioeconomic, including education, ethnocultural, family history. And some of these things we pick up without even asking questions, right? Sometimes we're wrong, but we profile. And you all do it too, just not quite as officially as we do. So the reality of it is what doctors do is they think in heuristics. They don't think in veteran doctors. There's a lot of push towards algorithms for newly minted doctors because you do A, then B, then C. But you know, you take a guy like Dr. Scott, who's in the emergency department, he goes from A to G to Z or Z like this, right? So that's how we think. We make assumptions, we profile, and we make assumptions. So, as he was good enough to point out, 2 patients come to your office, new and unusual left-sided chest pain, definitely some pain in their upper left arm, maybe a little more fatigue than usual. Who's having the heart attack? It's pretty clear, okay? So how does this apply to your visit to your GP? So, even though you've done your research, and I'm thrilled that you've done your research, don't come in with a definitive diagnosis, okay? Why? Okay? So this is to start with, this is a little obnoxious, but it is what it is. Does anybody know who Raymond Floyd was? So Raymond Floyd was a pretty famous golfer, okay? And does everybody here know enough about golf that if I tell you a little thing about golf, you'll understand what I'm talking about? Okay. So Raymond Floyd once wrote an article that I read that had to do with, I don't know if you know this, but golfers often play in what they call pro-ams. So an amateur golfer gets paired with a professional. And what he wrote in this article was, one of the things that amateurs like to do, so the pro comes to your home course, and you've been playing there for 25 years, and you know every tree, you know every break in every green, you know every blade of grass on the course. What you'll want to do is tell Ray Floyd how much you know about your course. Don't bother, because in 5 minutes of looking at your course, he will know more about your course than you've learned in the 25 years. It's just true. And as it happens, I was at the Canadian Sports Hall of Fame induction ceremony the night before I got here, and I was sitting with 3 women who were all Olympic gold medalists and all recipients of the Order of Canada, which is our OBE equivalent. And I told them this story, and they went, yeah, it just is. We just know stuff. It's just one of those things. So that's why, but it doesn't mean your input isn't important, but just you have to accept the fact that we just know. So here's 2 more reasons. Doctors we don't make definitive diagnoses unless it's so patently obvious that we can't help it. But as it happens, so we ask appropriate questions and we come up with what's called the differential diagnosis. Again, and that diagnosis is ordered not from top alphabetically. It's ordered by what's the likeliest thing, what's the least likeliest thing, with one caveat. And that's the 95% rule, because what I've been taught is that of the people that go to a GP, 95% of them will get better if you do anything for them or not. So I've got to figure out if you're one of those 5% and fix it, okay? So that may be on the list, even though it's relatively an outside chance, I at least got to do that. I heard a story yesterday about a couple of days ago from my doctor whose uncle died in a hospital in Calgary for basically no apparent reason because they didn't look for the one that would have killed him. Anyway, so that's the first thing. And the second reason why is because you've educated yourself to some degree, and that's great, but at the end of the day, you're still guessing, okay? And so nothing good comes from guessing. Why? Because if you're right, you're going to feel good about the fact that you were right, but it doesn't add much value because we're all going to get to the answer eventually, the right answer anyway. But if you're wrong, you may have done yourself a tremendous disservice and actually made things worse. So, how can being wrong make things worse? There's 2 ways to be wrong. One is that you think it's something serious when it's not, really. And why is this bad, besides wasting Dr. Scott's time? One is that you're going to create anxiety for no reason, which happens a lot. 2 is that you're going to wind up having increased testing to make sure that it's not something you're convinced that it must be. And testing is not benign, okay? There was a story last week that I heard from somebody last week. It was actually in the paper about a fellow who died after becoming incredibly ill from having a prostate biopsy and was dead in 3 days from septicemia. It doesn't happen very often. You hope it doesn't happen, but it was in the newspaper. In his obituary, by the way, not as a news story. So here's another classic joke. You know, there's two people in the desert, and the first guy says, oh my God, I'm so thirsty. I must be totally dehydrated. And the other guy says, oh my God, I'm so thirsty, I must have diabetes. And the other thing is that it may wind up undermining your trust and respect for your healthcare provider, for your GP. So that doesn't really help. The second way it can be wrong, which is the interesting one, is that you don't think it's a big deal, but it actually is something serious. And this, in fact, is the aspect of the internet that has the greatest value, because it does cause you to seek care when you otherwise may have ignored something. Okay? So, here's a case in point, Colin H. Colin H., not exactly as pictured. Colin H. came to see me, and here was his story. He was a lovely, lovely man. He was a 50-year-old accountant and just a very sweet guy. And he came back, he just got married for the first time at 50, and he came back from his honeymoon, and he comes in and he tells me this story. Dr. Greenburg, he says, I've just come back from my honeymoon, and I've been having trouble with my urination. I said, really? He says, yes, I've been having trouble getting started, and I find that I'm not quite empty at the end, and I was getting up more times at night than I'm used to, and I believe I have benign prostatic hypertrophy. And I said, okay, would you mind if I sort of examined you just to confirm the diagnosis? So why did he say that? Because if you look at a list of benign prostatic hypertrophy, and this comes from the Mayo Clinic website, so it must be credible, common signs and symptoms of BPH include frequent urgent need to urinate, increased frequency at night, difficulty start. So he basically hit for the cycle. He had everything that you're supposed to have. Except here's the part that he missed. They look the same so far, right? And here's a couple extra ones just for that don't even necessarily have to happen. But so I went and examined him, and unfortunately, what he actually had was advanced prostate cancer. So here's my, I always got to put in a little plug for the one reason why every man should go to the doctor, because you need to get examined. But, and it was one of those ones where, as soon as I examined him, it was no question what it was. Oftentimes prostate cancer can be a little tough to tell. This was like an absolute no-brainer. But at least it got him to come and see me, right? And at least he was kind enough to allow me to examine him so that I could actually figure out what was wrong with him. So here's some symptoms, and again, this is apropos to Dr. Scott's talk. Here's some symptoms that people think are a big deal but often aren't. So a headache that persists over days. Why isn't that a big deal? Anybody? Oh, come on, you answered his questions. Give me a break. Why isn't it a big deal? Okay, I'll answer. It's not a big deal because it's not about the duration, it's about the intensity and the onset, okay? I've had this horrible headache for a week. Anything else along with it? No. Anyway, that's one example. BRBPR, anybody here besides the doctors know what that stands for? That stands for bright red blood per rectum. That's when you've got bright red blood coming out of your bum. Scares the hell out of people. Big deal? Almost never. It's either a hemorrhoid or a fissure or something like that. Back pain that doesn't have any leg symptoms associated with it. We've already talked about that. I just had my back reconstructed last November. I had no pain in my back at all. My leg locked up. That's how I found out, okay? That's scary. And scrotal lumps that aren't actually in your testicle, guys, anybody? There are very few things that will get a guy to a doctor. But one of my favorite phone calls is, well, David, I got a problem. Okay, come this afternoon. No, I need to see you now, okay? When a guy finds a problem in his privates, you can't make him not come, okay? But most of these lumps are meaningless if they're not in your testicles, right? They're in the plumbing that goes around the testicles, okay? So not a big deal. And anybody know what these are? I bet you there's people here that have dozens of them. It doesn't photograph very well. These are these little red spots that everybody gets all over their skin as they get older. Cabell Morgan spots. Excellent. Can we give her something? Yeah, excellent. Thank you. So they're called Campbell to Morgan spots or cherry hemangiomas, and everybody thinks they're cancer, but they're not. Okay. So on the other hand, this is an important one. Coughing up blood. Now again, we don't have a lot of TB in Toronto, so this is a little Toronto sector. So generally speaking, people aren't coughing up blood. What they're doing is they're spitting up blood. So they get a bit of it dry. In Canada, we have very dry air in the wintertime because that's how we heat things by taking the water out of the air. So they get irritations, they get a little blood drip down the back of the nose. Then when they spit all this stuff up in the morning, it's got some blood in it, so they think they've got it. But there is one scenario where coughing up blood, besides the TB thing, where it can be very serious, and this, of course, is if you're Carmen and it's the end of the opera, and if you're coughing up blood, nothing good is going to come of this. It's actually a classic movie and opera and theater trope. Anytime you see anybody go to their mouth with a handkerchief and there's blood on it, you know they're not going to survive the end of the picture, whatever it is. So, on the other hand, here's a bunch of stuff that people don't think are big deals, but doctors see as red flags, okay? And one of them is asymmetry, okay? We talked about it a little bit with the stroke thing. Everybody do this. I need you to do something interactive because nobody's wanting to play along. Everybody go like this, okay? Look at your thumbs. Are they identical to each other? No. So, there's some element of asymmetry that we will accept within a variation, but if one side of your face goes numb, or you've got swelling in one leg, or anything that's just on one side, you better see somebody. Who doesn't really, this is a different story. A thunderclap headache, as was pointed out, it's the onset and the worst headache I've ever had in my life, or a change in a long-standing pattern. That's something that we take seriously. Any blood in your urine, okay, especially men, now that's in your urine, which is sometimes a little difficult to tell for women, but in men, there's a big campaign in Canada called Seeing Red, right? So if you've got blood in your urine, you better see somebody about that. What else we got? Any blood in your, so remember I said how about bright red blood from your bum is not scary? If it's mixed in, so it looks marbled, that's scary. Okay? Or if it's black and like not dark brown, but like tarry black, that's scary. Okay? And new onset hernia in older men. We heard about the guy with the umbilical pain who's 80 years old. Why would anybody care about a hernia in an older guy? Why would that be meaningful? It's a hernia. What's a big deal, right? You get a truss like your grandfather had and you're fine. Anybody want to guess besides the doctors in the room? So old men get hernias because they cough a lot, okay? Because they've got lung cancer. Old men get hernias because they start straining for bowel movements, because they may have colon cancer. Old men get hernias because they start straining when they pee, because they've got prostate cancer. So again, not a big deal, not high on the list, but of that 95% rule, I got to know that, okay? But again, these are the kinds of things, it's not a big deal. And again, the sense of urgency is a whole other thing. Any postmenopausal vaginal bleeding is never, ever, ever acceptable, ever, okay? Why new onset erectile dysfunction? What's the big deal? The obvious answer notwithstanding. Great relief to many wives in this world, but why is it bad for the guys? Say again? Prostate's a good guess, but that's not the one I'm thinking of. I'll tell you a story. So once upon a time, there's a very flamboyant urologist in Calgary. His name's Jay Lee. And he just moved to Calgary, and he had a meeting with a patient and who came in to see him for erectile dysfunction, so he sent him for a stress test for his heart. And he wrote on the requisition, the reason for the test was erectile dysfunction. The cardiologist, who didn't know Jay Lee from a hole in the ground, called him up and started wailing at him. Why are you wasting my time sending a person with erectile dysfunction for a stress test? And Jay's response was, look, your organ's job is to pump blood to my organ, just do the test. So the fact is that we talk about erectile dysfunction as being the canary in the coal mine. Arteries have no brains. They don't know where they are in your body, and they get progressively smaller from your penis to your heart to your brain. So if there's blockage in one place, there may be blockage in other places. So again, if a guy comes with the proper profile and he's got erectile dysfunction, your job is to make sure he's not having a heart attack vis-a-vis the 95% or having angina or some sort of cardiovascular disease. Any pain that wakes you up at night is never a good thing. And it's really important to think about, did you get up because you've got pain, or did the pain actually wake you up? And finally, any change in a long-standing history, we heard that before, something you've had for years, but all of a sudden now it's different. So a couple of years ago, I had a guy come to see me, an old patient of my father's, and he said, you know, I saw your father 30 years ago for some indigestion, and he gave me an antacid, so I just need a prescription. And I looked at him and I asked him a couple questions. I said, no, what you've got is the Widowmaker, and you need to go to the hospital right now. So the Widowmaker, as some of you know, is a 90+% blockage of your left main stem artery in your heart. And he looked at me like I was out of my mind, and he said, I'm going to go home and think about this a bit. And he did, and 2 hours later he went to the hospital, and the next day he had 3 stents put in. So, but again, he thought it was just, you know, same old thing, but it was different. Okay, so when you go to the doctor, what do you need to be? You need to be candid, not just honest. What's the difference between honesty and candor? Anybody? Bueller? You guys are, I don't know what, you worry out? I don't understand this. When you go to court, what do you swear to do? Tell the truth, and then the whole truth, and then to just cap it off, they make you put your hand on a Bible and say, so help me God, okay? So don't come to the doctor and tell the truth. Come to the doctor and tell them everything, okay? Really important. Second of all, be prepared, okay? What do you need to be prepared for? Okay, so here's what, you've got to provide a full and complete description of everything, okay? That's where the candid part's in. And the key is, I don't want to hear what you think is important, I want to hear everything, because it's, as per previous, you may think stuff is important that isn't, and there's stuff that may be not important that is, or you think is. So, these are the kinds of questions we need to know. Onset, duration, quality, happens once in a while, goes localized, radiating, so on and so forth. Okay? These are, you can have access to it after. I've actually got a couple of slides that are almost impossible to read, so for sure wait till it's on the website, okay? My apologies. Okay, so this is your strategy when you go to the doctor, keep calm and be prepared. Now, here's what else you have to talk about. Have you had anything like this before? When, why, what happened, what made it better or worse, how did it resolve? Recent lifestyle changes? My back's killing me. Really? Yeah, I started going to the gym and I started lifting weights and now okay, so any and all meds, and this is a big one, supplements, okay? There's several problems with supplements, and that's an entirely different talk, okay? But you gotta at least give me a chance to figure it out. And here's a really interesting one. This happened to a good friend of ours. This was a guy that suffered for 2 years. Kept going to New York. He was in New York, kept going to the doctor. I don't understand what's wrong with you. I don't understand what's wrong with you. Well, what was wrong with him was he was drinking 2 liters of Diet Coke a day. And everything he had was aspartame poisoning. Okay? Who'd have thunk it, right? These things aren't benign necessarily. Any family history are similar, and please always remember your brother-in-law doesn't count, because if you're not genetically related, it just doesn't matter, okay? And this one is really important. This is something that people don't take seriously enough, is that any changes in your mood, anything you're worried about, or anybody giving. So we had a doctor who taught us. His name was Ted Waring. He was self-proclaimed the most famous psychiatrist in Canada. Why? He'd been quoted in the National Enquirer 3 times, so he figured that more people had read about his stuff than any other psychiatrist in Canada. And he said, you know, there are 3 important questions to ask at the end of every interview, which have to do with the fact that, you know, is there any, you know, are you depressed about anything? You know, or anybody giving you a hard time about anything? Are you worried about anything? Okay? Because it's quite remarkable vis-a-vis the 16-year-old girl or the 18-year-old girl who's upset because, you know, she's had sex with her boyfriend who her father doesn't like or whatever it is. I mean, look, there's no mind-body dichotomy, right? It's all one thing. And your ability of your mind to interpret different physical symptoms or actually create different physical symptoms is not something that should never, ever, ever be ignored, okay? But again, you gotta own up to it, you know? So, when your healthcare provider tells you what they think and what the next steps are, if you're not clear about why, okay, why they decided what it is, or what they think it might be, or why they're doing the things in order that they're doing them, it's important to respectfully ask them to explain why. That's a completely reasonable question, okay? However, don't ever ask what it could be, okay? Nothing good comes from this question. And what doctors are good at is what is, not what if. Okay? We're going to try and figure out what it is. And again, when you start to ask me what it is, right, what it could be, you're asking me to guess. And I don't want to guess. But having said that, there is one exception to this. And I think this is important because, you know, it speaks to why the guy with the 170/90 blood pressure and itchiness in his privates came in, okay? Which is that if you are particularly anxious about any one thing, right? You think you might have cancer, you think you might have heart disease, you think you might have MS, and you find that particularly scary, and it came up in your research, it's okay at that point to respectfully ask, okay, David, so why isn't it that? Or if it could be, can we please just do something to rule that out? That's an okay question. I'm totally okay with that question. So, what about follow-up? This is one of those slides that I want you to take off the internet because it's too much stuff going on. So, one of the things, this actually doesn't just apply to physicians, it also applies to chiropractors and the people that are doing things to you. It's completely okay to ask what the testing is going to be like or what the treatment's going to be like. And it's important for us to explain that because managing patients' expectations ultimately may be the single most important thing that we do. Why we're using it, rationale for its use, an overview of how it's going to be done. It doesn't have to be in great detail, but it has to be at least give you some sense of what it's going to be. A timeline for expected improvement. One doctor one time said to me that every time you see a patient, you should consider it to be the end of a clinical trial. Go back and look at what was wrong with them the first time they came in, and let's see what's changed over that time, okay? So if I see somebody on a Thursday who's got something relatively benign like a cough or so on, or a postnasal drip, and I give them something, if they say to me, if I don't say to them, you're not going to start feeling way better until Monday or Tuesday, or at least the trend isn't going to be, let's make sure the trend is positive, then you know they're going to call me on Saturday and ask me why they're not better yet. Okay? But sometimes, vis-a-vis the cellulitis, right, I'll draw a circle around something, start them on a high dose of antibiotics and say, I want you to call me at 8 o'clock tomorrow morning after your 4th dose of whatever it is, and if it's outside that circle, we'll talk because you're probably going to wind up needing to go straight to A&E for IV, okay? So just giving people a sense of what that timeline is actually gives them a great sense of comfort and actually makes your life easier as well as a physician. And then, how do we know if you're getting better? This particularly applies to people like chiropractors who people will walk in and, you know, doc, I've got back pain. Okay, great. So I'm going to see you 3 times a week for the next 12 weeks. How do you know that? And how can we tell if I'm getting better or not? Okay? So asking those things and having reasonable milestones as to when can we check and see if I'm okay, and do I need to keep coming? And then finally, that was too fast. At every visit, it's okay to ask the question, am I getting better? Am I making progress? Are we doing okay? Do we need to change course? Okay? So, finally, if you still feel strongly about doing your internet research, and I want you to, all I did was Google, because I went to a bunch of doctors that are my friends and colleagues who I trust, and they all basically said, I don't know. But here's what you can do. I Googled just this topic, academic research on which medical websites are credible. And these 3 websites were pretty reasonable, and they gave you insight into how to tell if the info you found is likely to be credible. So one is from the National Institutes of Health in the United States. One is from Johns Hopkins. I didn't see any of their senior doctors being implicated in the last couple of weeks, so I presume they're still okay. And the Center for Disease Control, also, I think they're probably pretty credible. Okay? And there was one thing that I left out that I meant to say. So if you're, one of my problems is that when I have students, I will say to them, this is the most important thing I'm going to tell you ever, probably 5 times a day. But just remember this always. Everything that makes good medical sense should make good common sense. Okay? I should be able to explain it to you in such a way that makes perfect common sense to you. However, everything that makes good common sense does not make good medical sense. So that jump to conclusions, why I've got this, therefore it might be this, well, you know, it's not really possible because those 2 body systems aren't really connected to each other in any way, shape, or form, okay? But again, if it's presented to you in a way that doesn't make sense to you, ask, because it should be explicable in terms of common sense as well. So, like, can't we all just get along? Like, stop, you know, like, I don't understand the world anymore, but has anybody ever seen this Listen Linda tape? Yeah, my daughter showed it to me. She constantly in our house, she's saying, listen, Linda, so. But I think that if everybody goes in with the right attitude, the fact that you're now empowered can be a really great thing. But I think it's really important to remember that it's a 2-way street and that we're trying our best. I don't go to work in the morning for any other reason than to try and make you better, okay? And don't forget that, especially in Canada. I don't make any money, so it's not about that. Yes, Gary, it's true. So it's just about, I get up every morning trying to make sure that the 40 or 50 or 60 people I'm going to see that day get better. And that's my motivation, and that's why I'm here. And I can't thank you enough for putting up with me, and thank you, thank you, thank you. And I hope it's helpful. And if you want to ask me some questions now that you've been like crickets for the last hour, that would be really helpful as well.
Thank you so much, Dr. Greenburg. Does anybody have a question for Dr. Greenburg? Because we do actually have a few minutes where you can ask a question.
Spoke too quickly.
Oh,
yes.
We need a mic in the front. Wait, Ginny. Shireen's coming. Right here, Ginny Hobday in the front, Shireen. Here she comes.
I can, but I don't think anybody else can.
Yeah. Try again, Ginny. I think you turned it off. Yeah, try again. No?
I'll leave it to the professionals.
You're all going to be expecting something fantastic now, right?
That's right. The anticipation's killing us.
Yes.
Ginny.
No, thank you very much. That was very helpful. And for me as a general practitioner, that encapsulated a lot of what I wish we could tell people, you know, because there are things they worry about and needn't worry about, and there are things they don't worry about and they really do need to worry about. One of the things that I find that people don't do themselves a service when they come to the general practitioner is they sort of say, well, I come once a year and I've got 15 things to tell you about. How do you expect your general practitioner with a fairly short period of time, you know, to do 15 things justice? And, you know, you don't want to put people off, but I do think it's something that if you're an empowered patient, just try and think about how the person opposite you is going to deal with all that information. And I think you get a much better result if you know, deal with the essentials.
We can share this out loud because, you know, we're all in this together. A GP's 4 least favorite words are?
By the way?
While I've got you.
Okay. And another question over here, Dr. Yin. Oh, before Dr. Yin, sorry.
I just want to ask a question. Why, when patients go to doctors now, the doctors don't ask much question to the patient? because sometimes maybe they can save them through asking. Sometimes they leave and say, oh, I forgot to say. God, the doctors nowadays, I don't think they ask much questions.
Well, I'll tell you a story about that. There's a couple of reasons. First of all, I can't account for why anybody does anything the way they do it, okay? But I'll tell you a story about my dad. So many years ago, my dad went and made a house call on this woman and listened to her, and she was coughing. So he listened to her chest, and he did something called, I mean, my dad was an old school great doctor, so he did this thing where he did what we call vocal fremitus and tactile fremitus, and he did all these really, older but tests that we don't use anymore. And he determined at a house call that she had a lung abscess. Now, lung abscess is pretty rare and pretty hard to discern on a clinical exam. So he did what my dad did, was he called his friend who was the chief of respirology at the local hospital, and he was very proud of himself, he described all these symptoms, and he said, this is what's wrong with her. And the response was, oh, Jesus, Joe, just send her down here for a chest x-ray. I haven't listened to anybody's chest in years. So what's happened is that there have been technological advances that have replaced, there's never the need for some of the questions, okay? So that may account for some of it, okay? For example, when people cough things up, we used to spend a lot of time asking what color the sputum was. We don't do that anymore. So that may account for some of it.
Yes, because sometimes
Yes, so and you just have to hold it right up to your...
sometimes the patient go for one thing, but they only deal with that one thing, but they don't ask, like, what color your stool is, and so, and...
Right. So again, that's a great question. So getting back to the way doctors think, okay? Doctors think because your body can be divided in a lot of different ways. One is you can divide it anatomically, which is which parts are connected to each other, but we can also look at it systemically. So for example, if you look at again, at the A&E visits, right? If you had, let's say you were doing your final exam in either general surgery, gastroenterology, obstetric and gynecology, and the examiners needed to ask the student one question that it took them 3 hours to answer. There's one question. A woman of reproductive age presents to your office with right lower quadrant of abdominal pain, discuss. Because there's at least 3 hours worth of stuff going on in this part that are related to each other, okay? But an ultrasound will rule out lots and lots and lots of them. But we know that if you've got urinary tract symptoms, could it be related to gastrointestinal tract? Yeah, because we know constipation can be a risk factor for urinary tract infections. But I don't necessarily need to know what color your stool is, but it would be an important thing to ask. But if a woman comes in and says, my husband, I don't know, do people still here talk about honeymoon cystitis? Yeah. So, I mean, a woman comes in and she's got a urinary tract infection. Did you have sex last night? Yeah, it was great. Okay. So, oh, sorry, that was... I don't really need to know necessarily anything else because that accounts for it. But getting back to my point about reasonable timelines and managing expectations, right? If you come back 2 days later with a fever and the pain's moved, different story. Okay? So the nice thing about being in general practice, as opposed to being a walk-in clinic or an A&E doc, has to do with continuity, right? I don't have to be right the first time. I just have to be in the right direction and make sure that I've explained to you what appropriate follow-up is so I can tell what the next steps are. Does that help?
Yeah, last question,
Okay.
Dr. Yin.
Oh, very good presentation.
Thank
I'm a
you.
GP myself. And, there's something unique here about Cayman Islands in the general practice, right? In most countries, they stick with one jurisdiction and you're a GP, in that particular area. And so you look after almost the whole family. Whereas here, there is a culture of what we call doctor hopping, doctor shopping. When a patient comes and see you, and they have got this perception that this is what's wrong with them, but if you rule it out and say, no, I think you're not in the right road, let's go down looking this side, they're so affixed by the internet that will
Right.
say, oh, I'm just going to go to Dr. A over here because of B over here until they hear what they want. So that's first observation I have since the internet.
Right.
Because in the old days, you just basically will be explaining to the patient what you're doing and then get to the right diagnosis. Second thing is that I always encourage my patients, to stay with the same practice, whether it's the same doctor they're saying, maybe there are 2 or 3 GPs in one practice, stay with the same practice because we know your family history, we know your history. I mean, I've been here 30 years, I've looked after grandmas to babies and now they're growing
Correct.
up. And so the family history is already in there. So doctor hopping is extremely dangerous.
It's a big problem.
Yes, and
Agreed.
also here, our pharmacy, we don't have a central zone, right? So they can go to different doctors being prescribed different things that could interact, and the pharmacists have no idea.
Yeah, it's
So those
interesting.
are the thing that are actually the patients are endangering themselves.
Right.
And I agree with Dr. Hopday about the 15 things, and it's always the last time, just as they're getting out of your office, by the way, that's the one that's what they worry
Exactly.
about.
We call erectile dysfunction a door handle diagnosis. Have you ever heard that before? Guy comes in, talks about a whole bunch of things. Oh, by the way, I'm having some issues. But I just want to say, too, those are really, really excellent points. One of the things that I was involved with over the years is sort of trying to encourage Canadian doctors to prescribe antibiotics appropriately. And one of the challenges historically was, look, doc, I got bronchitis, the same bronchitis I have all the time. I need an antibiotic. No, you don't. It's viral. Well, look, I'm just going to go down the street and get the prescription from somebody else, so why don't you just write it? Okay? One of the beauties of being in general practice, and like you, I've delivered babies of babies that my dad delivered. So we go 4 generations this way and big families across this way. So having that background and also gives you a chance to earn the trust and respect, right? If you've got that kind of continuity and they obviously respect you, you would hope that they're going to have enough sense not to jump around. The other thing my dad used to talk about was the demise of the local chemist, of the local pharmacist. Because what happened was you had a small shop. They knew what you were buying, even if it wasn't prescription. And my dad used to tell a story about him getting a call from the guy around the corner who said, Joe, I don't know if you know this, but this patient of ours, look how cute you are. They're contagious. They make you want to have more. But I think the real reason they're so cute is so you don't kill them. But anyway, so this pharmacist called my dad and said, Joe, I don't know if you know this, but this patient of ours has been buying a bottle of aspirin a week. Who would know that now? They're more interested. No, I'm not saying they're more interested. It's not a slam on pharmacists, but they sell toilet paper now, and they sell other things. And the idea that and the pharmacist himself will never see what they're getting off the shelf. So that's a real problem. And you go to the internet, self-medicate. So at least if people know that rule about, even if you impose it on yourself, how do I know if I'm getting better? How long is it reasonable for me to try this until I am getting better? That at least will help, because if they come and say, you know what, I went to the chemist, I bought this, I've been on it for a week now, and it's not changing, isn't that a good reason to go see a doctor? Seems like a pretty good reason to me. Anyway, thank you so much. Please tell the committee you enjoy this so I can come back next year, okay?
Dr. Greenburg, I have a present for you.
Oh, good. Thank you.
Small token of our appreciation. Great, thank you.
Thanks very much. I'll take it back to you. Thank you.
Okay, so the winner of the Pinnacle Media Fitbit Versa was Teresa Brown, and I don't know if she's in the room. If you know Teresa, let her know. If you don't know her, well, I guess you can't tell her, but we also have some we have some found keys. So if you've lost your keys, everybody's checking, I got my keys. If you've lost your keys, we have them at the table in the back. You can check that on your way out. And also, as I mentioned earlier, don't forget that you can recycle your lanyards. Now, you can't leave yet, though, because we do have one more speaker who's going to bring it all home, and that is the Honorable Dwayne Seymour, who is our Minister for Health, Environment, Culture, and Housing, and he's going to come and give us some closing remarks. Please, big warm welcome for Minister Seymour.
Thank you. Good afternoon, everyone. Dr. Greenburg, that was a great job. I had one more question to ask you is, why does the symptom and the pain go away as soon as the doctor comes in the room? They told me that as Minister of Health, I've attended this event more than any other minister and made myself available. And I could only think that I actually needed to come because I'm actually the heaviest minister to ever be the Minister of Health. And, and I also understand that more ministers and MLA have attended this event this year than any other of the healthcare conferences. I must admit, I told them they were going to win a prize. They actually asked around, found out it wasn't true, and they all left. So I had to ask Captain Eugene to do a little BB King, stand by me. I trust that everyone has had an enjoyable and informative conference as we close out this 9th gathering of the Cayman Islands Healthcare Conference. And what a conference it has been. As always, we continued to be blown away by the record numbers of attendees. Over the 3 days, we are pleased to have welcomed over 1,200 attendees. And we hope that every visitor was able to take away something beneficial that we can apply either now or in the future. With that in mind, I want to thank all the vendors and many sponsors once again for being a part of the healthcare conference and making it a resounding success. For those who support us each year, we appreciate your continued support and commitment to the healthcare conference. For those who are new to the conference, we hope you had an enjoyable time, and we look forward to developing an ongoing partnership for future conferences. To all our local and international healthcare providers who take part each year, thank you for continuing to support us with your valuable time. We appreciate your effort to share your valuable expertise and for doing it in a fun and interesting way. Our healthy turnout each year is a testament to these efforts, and the healthcare conference continues to be an event that our community look forward to each year. We have heard much over the past 3 days about issues related to this year's topic. Managing your health, the empowered patient, a topic that I firmly believe is extremely important in assisting our Cayman community to feel empowered and take control of their health. With all the information we have taken in over the course of the conference, I feel one of the main takeaways from this conference was communication. Open communication between healthcare professionals and patients is the key to empowerment. In an age where communication has never been easier due to the advancement of technology, it can be easier to forget how important it actually is. Communicating helps people to express their ideas and feelings, and at the same time helps us to understand emotion and thoughts of others. In healthcare, communication is the most important component of healthcare professionals working with patients. It is the cornerstone of their interaction with people. A good and effective exchange between people helps them see what the other person thinks and how he or she feels. It helps people understand each other better, and as a result, it brings them closer together. Over the past 3 days, we have heard about controlling and living with non-communicable diseases. We heard on the opening night from Dr. Gary Sibald and Miriam Botras on living with diabetes and the advancements in the area which allows patients to manage and control their conditions. We heard from Dr. Sally yesterday morning on the amazing developments from Iron Shore Pharmaceuticals. Having made with drug developments for children suffering from ADHD, and just this morning we heard from Sutton Burke the importance of sustaining your mental health and implementing mind care practices. Each year, the Healthcare Conference aims to be informative and educational, and I believe this year was no exception. Our sponsors, speakers, and the Ministry of Health use this conference to try and make a real difference to the community here in the Cayman Islands. We want to reach as many residents of our island as possible, offering health and well-being solutions. Since its inception, that has been the aim of the conference, and I'd like to believe we have achieved this. Over the past 9 years, we have seen many changes in our community, which would not have been made if it wasn't for this healthcare conference. In fact, as we speak, some of the bills that we are preparing for the Legislative Assembly is directly correlated from concerns and questions that we got from this healthcare conference. As we come to a close today, the ministry is already looking to the future and putting the wheels in motion for next year's conference. Next year, we will be celebrating the Healthcare Conference 10th year anniversary. I am proud as Minister of Health to be able to celebrate a decade of bringing our community together to engage in the important conversation that is healthcare and wellness. I want to put you on the spot, but I think it is very important for us to include children in this movement. Sometimes it may look like we have lost a generation because of bad habits, but I think we need to look very carefully at the next generation coming and ensure that they get the right informed information so that they can make better decisions. And anything that we can do to include the schools in one of our sessions next year will be very welcome. We want these conferences to be meaningful. So instead of coming up with our own agendas, we reach out to you, the wider community, to listen, to try and address your needs through these conferences. We will do it with the feedback from the community, from you, our participants. Finally, I would like to thank our sponsors and speakers again for making this event a success. I want to also thank the public sector, the private sector, and the charitable organizations that have worked together to help us make this conference a reality. It has been a very full, informative, and educational 3 days, and I hope that each of you has enjoyed your time together, and actually some people enjoy their time away from work. Thank you, and God bless. Before we leave, I want to give the master of ceremony and one of the organizers of this event, Chief Officer for the Ministry of Health, Ms. Jennifer Ahern, a token of appreciation. Thank you.
Thank you very much, Minister, and thank all of you for being part of what I think has been another awesome healthcare conference. Thank you for sticking around to the bitter end. I know that we had some people need to slip away to get to, unfortunately, a funeral today. But I do hope, as the Minister said, that you've all found it to be informative, that you've all walked away with that, at least one little nugget of information that you know you're going to go away and apply in your practice for the practitioners or in your life for the non-practitioners, that's going to help make yours or your loved one's health health and well-being that much better. Please remember to recycle your lanyards so we don't have to put them in the landfill. Have a wonderful Saturday afternoon and a great weekend. And and don't forget your surveys. Minister mentioned those. Please, when you get the survey, give us your feedback, because we do use it to make plans for next year. Next year is our 10th one. It's going to be bigger and better than ever, and I'll look forward to seeing you all then. Thank you all, and have a wonderful weekend.